did briefly want to touch on alternatives to patients that do not want surgery, because I feel like a lot of my patients do not want to pursue surgery. There were a few updates in this space at ESMO. I was wondering if we could briefly touch on immunotherapy with chemoradiation.
This was a Hellenic study, actually. It was great to see my friends and colleagues from Greece, where I'm from originally, doing a very nice randomized phase 2 trial, looking at the addition of checkpoint inhibition to the backbone of chemoradiation after TURBT as a method, as a tool to try to achieve bladder preservation in patients who do not undergo radical cystectomy. So it was great to see that happening, and I think that phase 2 trial, it was very interesting. That's why we had it in the program, of course. This trial, I think it's still ongoing. Again, we need to have longer follow-up. The take-home point was addition of the checkpoint inhibitor with chemoradiation backbone seems to have a promising signal in terms of reducing the chance of recurrence and metastasis. And I think it's not practice-changing yet, but is raising enthusiasm for the 2 large ongoing phase 3 trials we have in the United States, the S1806, which is a cooperative group trial run by SWOG and with a participation of NRG, ECOG Akron Alliance. It's a cooperative group study, finished accrual back in February of this year, and hopefully we'll present some data in the future. This is chemoradiation plus minus atezolizumab after TURBT, and a similar study with a few differences is the Keynote 992 with chemoradiation plus minus pembro. So I think those 2 phase 3 trials will define the role of the additional value of checkpoint inhibitors to the backbone of chemoradiation. But the Hellenic group study from ESMO was very promising. Again, despite not being practice-changing, I think raises my enthusiasm to wait for those phase 3 trials.
Yeah, I will add to that by saying that, we spent a lot of this actually conversation talking about trials that include radical cystectomy, right? Because that really is right now the standard of care for the majority of patients. But I think the future really is hopefully bladder preservation, right? That especially now that we've, I think we've gotten to the point where we have really good systemic therapies, right? Much better systemic therapies than previously, hopefully, such as the new, immunotherapy ADC combinations like pembro and enfortumab that I think, would be very active in this setting and would allow many patients to hopefully preserve their bladder and avoid radical cystectomy. And so both of these trials that you mentioned with the basically checkpoint inhibition and radiation are huge efforts, right? And one of them a cooperative group study, and we'll hopefully see the results of that, reasonably soon, and that may expand, I would say, the use of this bladder-sparing approach. And there are other studies ongoing as well. I'll highlight a study that actually, hopefully, I'll be opening at my site soon at UCSF, where we're actually using, again, enfortumab vedotin and pembrolizumab as a radiosensitizing regimen in combination with bladder radiation, then followed by EV and pembro post-radiation as well. So, so I think there's a real future to studies investigating this question, and hopefully, excited as we are about Niagara today, hopefully, 10, 15 years down the line, we're talking more about studies and regimens that allow patients to preserve their bladder.
I think it's a great point, and Karine, I think you raised a great question. I think bladder preservation has an increasing role. I would argue that even now is a standard of care for some patients, and of course the big question is patient selection. And I know at all our institutions we think about patient selection in the appropriate setting based on tumor characteristics, patient factors, patient preferences, provider familiarity. In that context, a multidisciplinary tumor board or multidisciplinary clinic is very useful whenever possible to have the different experts in the room, as ideally collocated, but at least have these different options for the patients, radiation oncologists, med-onc, urologists. And Vadim is right. The majority of patients so far, at least in the US, they undergo radical cystectomy. That's the most commonly used approach. And I think in the future, I agree with you, we'll see more bladder preservation. And that may have different forms. Another question I'm sure you will ask, Karine, is in the future, not today, are we getting to a future state whether we can cure some patients with systemic therapy alone? That's a big question.
Right. I mean, we did see, the phase 2 Gemcis Nivo, and most of the patients on that trial elected to forego cystectomy, and the question is, are those remissions going to be durable? Can we be having discussions with patients, hopefully in the future, where we're offering them an option where perhaps they don't have the local toxicity of radiation as well?
I think it's a great question, and that Who's Your Cancer Research Network trial by Dr. Galsky, very promising in that regard, and it was a small, relatively speaking, phase 2 trial, small in the context not of phase 3, but still very promising and set the foundation for this discussion. And I think it was, if I remember, clinical complete response that was stringently defined based on imaging, MRI, cystoscopy, cytology. I think it was 43%. And I think all but one of those patients had a great long-term outcome based on the follow-up they had without cystectomy. So I think the notion is there, and I think as we get better with systemic therapies, chemo plus checkpoint inhibition, down the road pembrolizumab and enfortumab, or maybe the Volca regimen, as we get better with these systemic therapies, can we identify biomarkers to define clinical complete response and select patients? That's the pursuit.
Yeah.